Welcome. The Leukaemia Foundation would like to acknowledge the traditional owners and custodians of the country throughout Australia, and we recognise their continuing connection to land, sea and community. We pay our respects to elders past, present and emerging, and to all First Nations people joining us today. And I'm in Wurrung country. So I'd like to welcome you, our participants, and Dr Amanda Hordern. And the intention for our Sex, Intimacy and Blood Cancer, the Great Taboo webinar today is to open a discussion around the topic of sex and intimacy for people living with blood cancer. And it's really clear to us from the number of people here today that it's quite an important, possibly under-acknowledged and discussed topic. So to set the scene a little further, I'd like to share a story with you. So to introduce the next video, I'd like to introduce you to a lovely lady who's very generously agreed to share her story with us. So Susan received her blood cancer diagnosis not long after moving to regional Victoria. And she described herself at one point to me as just a woman with lymphoma, but she is so much more than that. She's an intelligent, vibrant and engaging woman with a zest for leading her best life. And her academic life means she's a very curious person and has a strong drive to find answers to her questions. And this led her to exploring and reimagining sex and intimacy in the face of her diagnosis and treatment. So through this experience, I've been privileged to meet and work with her, and she's graciously agreed to share some of this with you to introduce the topic from a very personal perspective and one I'm sure you'll be able to relate to. So let's hear a little from Susan.
My husband and I had just moved to the country and were really looking forward to our retirement when I was diagnosed with lymphoma. It was a terrible shock, but there wasn't really a lot of time to process it because by the time I was diagnosed, the disease was well advanced and treatment had to start right away. The diagnosis actually put a lot of stress on our relationship. I was sort of self-preoccupied with just coming to terms with the diagnosis and also the effects of the chemo. And my husband was experiencing a lot of anxiety. So we were both in our kind of little separate worlds of pain. And once we realized that, we just decided that we would stop and hug each other 5 times a day. I know it sounds a simple thing, but it really helped us to connect and to remind us that we were still together as a couple. We've always really enjoyed our garden, and another thing we did was that once a day we just went around the garden holding hands and looking at all the new flowers and plants and discussing what else we might plant. Again, just a simple thing, but it helped us to reconnect with those things that we've always enjoyed and to be together as a couple. During my first round of chemo, a wonderful oncology nurse named Claire came and spoke to me about sexual intimacy and how the cancer and the chemo might change things. She explained that, I might feel different and that we might need to be a little bit more creative and certainly a lot more patient. She also gave us a booklet which covered the topic as well. I know everybody's experience of chemo is different, but it really hit me like a sledgehammer. And to be honest, during that first round of chemo, sexual intimacy was the last thing that was on my mind. I felt that my body that I'd known for the last 63 years had been zapped and replaced with an alien body that I didn't have a user's manual for. I'd also been on hormone replacement therapy, but my oncologist wanted that to stop immediately. So that was another difference. My body certainly did feel different, and to be honest, it was only really towards the end of the second round of chemo that I started to feel a bit better and that sexual intimacy might be possible. Our sex life has always been really, really important to us as a way of connecting and making each other feel good. And I know there's a lot of different sexual practices, but intercourse is our favourite thing. So I was quite dismayed when I read in that little booklet that Claire gave me that only a water-based lubricant was suggested. I spoke to Claire and I sort of said, look, at my age, a water-based lube doesn't cut it at the best of times. And it was at that stage that she put me on to Jenny from the Leukaemia Foundation. Jenny was able to recommend a good lube, and we worked out that the suggestion of a water-based lube probably wasn't relevant to me. The next problem I had was that I found I was really sore. I even went to my GP just to rule out any infections, but we worked out that it was really a combination of the chemo and the antibiotics that I was on. So although intercourse was off the menu for the moment, we made time for sexual intimacy. So it was just this wonderful thing to be able to set aside that time that we just have for each other, concentrating on each other and connecting. And we found lots of ways of using that lube that didn't include intercourse, but made us very happy all the same. I'm very happy to report that after the chemo finished, we were able to get back to our normal beloved intercourse. However, the lymphoma decided that it was going to come back, so I'm on chemo again. And again, I'm really sore, so intercourse is sort of not possible. But we still put that time aside for each other, and the side effects of the chemo are not now so shocking for both me and my husband as they were that first time. And we've learned from our first experience how to keep our relationship strong. It has been a really difficult year, but I can honestly say that we're closer than we've ever been. And we just really enjoy every day that we get to spend with each other.
I think we can agree that Susan is an incredibly articulate and generous person for sharing that with us, and introduces us beautifully to a little of what is a really important aspect of life in our relationship to ourselves and our relationship to others. And unfortunately, it's often neglected in the shock of diagnosis and survival, and it rarely gets raised as an important part of health when living with a blood cancer. So Susan has set the scene beautifully for our topic today, sex, intimacy and blood cancer, the great taboo. And it gives me great pleasure to introduce our esteemed guest speaker, Dr Amanda Hordern. So I'm going to tell you a little bit about her, and then we can get to the crux of her expertise. So Dr Hordern is an experienced leader, manager, educator, counsellor and program developer. Her qualifications include a PhD focused on the impact of patient sexuality in the context of cancer and palliative care. She's nationally accredited hypnotherapist, a master practitioner and trainer in neurolinguistics. She has 30 years of experience in oncology and palliative care across a range of clinical settings. She started out as a cancer nurse and developed an interest and expertise in patient sexuality and intimacy after cancer. She's delivered support and practical strategies, which we know from your poll is important, to numerous patients through counselling, workshops and developing print resources. And she's used her research findings to develop health professional training in sexuality after cancer. And this has been incorporated at a state, national and international level. She's the Managing Director of a counselling practice in metropolitan Melbourne. And of relevance, she's recently launched her ebook, Sex and Cancer, Connect with Your Body and Rekindle Your Spark. So let's hear about the spark, and I hand the floor to Dr. Amanda Hordern. Thank you so much.
Thank you so much, Jenny. And thank you, Susan, if you're, or when you go to re-listen to this, because I know that you're not perhaps here today, but thank you for your beautiful introduction that is, like you said, Jenny, a perfect segue into a really important topic. So what we're going to do is I'm just going to share my presentation with you. So I wish I could see you all, but I'm so glad that you're all there. And I am just opening it up now. And what the beautiful work of Susan has said is, you know, it's really important to let's start at the beginning. I loved her words that we're closer than ever, and that we hug each other and we hold hands each other. And we're going to revisit that shortly. But before we even start, we're going to go back to the real basics of what does sexuality and intimacy even mean? Because as Susan said so profoundly, it does mean different things to different people at different stages of their life. We're just going to very briefly talk about the sex benefits of intimate and sexual well-being, as well as just looking, even putting cancer and blood cancer to the side slightly, just to go, irrespective of aging, our body changes and we can remain a sexual being from the moment we're born until the moment we die. And as many of you have alerted to or alluded to in your pre-conference questions, it's really important to be able to raise the topic, to feel comfortable about it, but also to know what to do if you don't feel comfortable about it. And most importantly, as your great polls suggested, we want the practical strategies. Let's stop the academics and let's get to how do I move forward after this experience. So just going back to what sex actually means, I think it's really important to remember that we live in a world that bombards us with these wrinkle-free, pubic hair-free, disease-free images of these plastic bodies all around us. I mean, this one was at a bus stop, would you believe? It's very hard to get your bus when your eyes are peering to the heavens like this. But everywhere that we see these messages, we're being subliminally told that unless we're looking like this, disease-free, pubic hair-free, wrinkle-free, flab-free, then we're probably not going to be sexual beings. And so we look at these, and sex probably sells cars more than anything else. I mean, it's hard to actually work out what car she's selling when you look at her beautiful body and his beautiful body, and it's all the way around us. And the reason that I'm saying this is that often as health professionals, and very particularly often as ourselves, we can be vulnerable, even worrying about, is it important? I've got issues about sexuality that I want to address, but, you know, should I be grateful to be alive rather than, which was one of your questions, than focused on my sexual and intimate well-being. Now, I know most of you are peering very closely at this just to see if she does have a G-string on or not. We can't even work out what she's selling, can we? And when I was quickly flicking through my slides over the weekend, my partner walked in and he said, I don't care what she's selling, she's great. And it's this thing over and over again that when we have these images all around us like this, it's hard for us to feel sexual beings when we've got a nasal cannula on here to get oxygen. This woman's family sent me this photo from New Zealand. I'd been over giving a sex talk in a palliative care unit about how to bring the greatest taboo out of all just before you die. And this woman said to tell the nurses and the doctors that this is what sex means to her. Floating in a bubble bath, having the syringe driver disconnect, having some peace from being disturbed and interrupted by staff and being left alone to listen to music, float in some bubbles and just have some time to reconnect to her body. And the amazing thing about this story is that she died 3 days after this photo was taken, but she wanted her family to pass on to her health team that this was a really important moment for her, and she wanted to thank the team for letting her do that. So when we're bombarded by these images all the way around us, we've got to be beautiful and flab-free and wrinkle-free and disease-free. Then when we're struggling with health-limiting illness, or when we're struggling with new diagnosis, or at the end of active treatment, when our body's not quite feeling up to it, as Susan alluded to as well, it's often hard to think that it's okay to raise the topic and to put some energy into the intimate and sexual worlds. So most people say to me, how do I manage all these changes? Will my partner still be attracted to me if I do have a partner? But as one of you suggested, I want to know how to do pickup lines for a new partner when I'm going through treatment or when I've finished active treatment. How do other people cope? What if I fail at sex? Are there practical things that I can do to reclaim the spark? And we're going to talk through all of these in a really fun and flexible way. And then we're going to allow lots of questions at times at the end. And you would think that it's probably a pretty basic thing to say, why do we even start with a definition? Well, if we're bombarded by these images all the way around us, alluding to penetration and genital and orgasmic and libido and frequency and coital frequency, that's pretty much what our world thinks. It's a genital experience only. That's why I love this definition by the World Health Organization that says it's about our mind, it's about our thoughts, it's about our fantasies, it's about our desires, our beliefs, our attitudes, our behaviors, our practices, roles, and relationships. So it's way more than penetration. And the beautiful thing about Susan's story is that even though penetration and intercourse was a really, and is, and continues to be an important part of their loving, deep connection, that, as she so powerfully said, was the one thing that we just share with each other. It's that one reconnection that we can do as a couple, that what she didn't say was, rather than giving everything else out to everybody else, it's our thing. But for most of us, it's really important to remember it's not just about penetration. So that if that's out of bounds for a while, or if that's off the option list for a while, then there are other ways that we can explore our sexuality. And in summary, sex means different things to different people at different stages of our life. What does intimacy mean? It's often bandied around by us as health professionals, who we often feel vulnerable to raise the topic. We squirm, and we're going to briefly look at that, what goes on for us as health professionals. So often intimacy is just flagged as something, and this is a beautiful Cancer Council reference. It's about being loved, showing that you're feeling valued, and demonstrating a mutual reciprocal concern and care. And like Susan's story said, they were both going through their joint, but, like parallel pain experiences, a powerful way for her to share that as well. The good news is that, things change to us. The good news is that sorry, I just clicked too far then, that sex, when it's in a loving, reciprocal way, when it comes from a place of freedom and choice for ourselves as individuals, and or with a partner that we may invite into our intimate and sexual world, it can lower our stress and anxiety. It can improve sleep. We know there's evidence behind all of this. It has even been shown to reduce the perception of pain, because often we hold a lot of pain in our mind, and our body's like a robot controlled by the mind. So we know that after a good, loving connection, whatever sex means for that person, that the perception of pain can reduce. But as Susan's story so powerfully demonstrated, it's replicated in data to show that it permits people to adjust to the changes, and in a fun and loving and intimate way. And there's a word that's been bandied around by this wonderful group of researchers, Professor Jane Usher, Professor Jeanette Pertz, and others at the University of Western Sydney, that showed a whole group, that there were hundreds and hundreds of carers. Now we know that, in this group here, it kind of represents that we've got a smaller amount of people who are walking closely beside the one who's having the cancer or the blood cancer experience. And it's often hard to get really good data. And the carers, 2/3 women, 1/3 men, said that they had a better relationship. 16% of them could find ways to have a better relationship than before the cancer experience, pretty like Susan's. And we're going to work out how they managed to go from the shock and the trauma and the horror or the uncertainty and the fear of a new diagnosis to re-flicking the switch of the mind to the fun and the deep connection, where they too, only 16% of the hundreds of people that were interviewed were able to have a better relationship. And Susan would be in that category. But I never used to talk about this until I started getting questions from the cancer community that made me realize that we don't talk about natural aging. And I remember thinking this as I was lying in the bath once, very heavily pregnant, and I looked down and thought, oh my God, I've got a grey pubic hair down there. I'm having my first child. What will they think in the hospital, was my first thought. And I jumped out of the bath and I called my mum and I said, oh, mum, when did your pubes turn grey? And she said, oh, Amanda, I'll get back to you about that one. And she never did. And I called my grandma, who was in her 80s, and I said, oh, Grandma, when did your pubes turn grey? And she said, oh, Amanda, it's been so long since I've had any pubes that I can't remember when they fell out, let alone when they turned grey. And it made me realise that ever since then, that we don't talk about what happens to each of us, putting cancer aside for just a moment, that our vaginal tissue gets thinner and thinner every decade of life. that our labia, which is all of our external genitalia, so the vulva or the external aspect of our vagina, shrinks. And so then the clitoris can become more exposed. Now, this can be good or this can be okay, but it just means that there's always going to be change to our sexual health and well-being as our body naturally ages. And the most important message is that the more comfortable we can be in our body, the more that we can find other arousal pathways, because for some people they don't want to have genital sex anymore. So basically we change as we age, and our body ages with us, but it's not the end of our sexual well-being. Sorry to say, men, but it also happens to you. So each year, testosterone drops on average, 1% each year. And so there's often a lot of reduction in the times and frequencies that men think about sex, but also even in the length and what we call the girth, the width of the penis can shrink naturally without any chemical agents or active cancer treatment. Erections may take a little while to get up, or if any, it's going to be exacerbated. There's 50% of erectile dysfunction in the non-insulin dependent diabetic population. People who are on different treatments, antidepressants, there's high risks of erectile dysfunction and low libido for people as well. So that it can be a long, what we call refractory period between having an erection, if that's possible, and also then being able to ejaculate. And once again, the more comfortable we can be in our body as men, as with women, the more that we can start to explore other sensual ways. It's really important to emphasize to men, because most men don't realize this, that they can still have a full-blown orgasm, and we'll come back to that a bit later, with a non-erect penis. And that's pretty much like, people just walk out going, really? And so the big message here before we even start about the active cancer treatment is that as we grow older, we do in fact have the capacity to become more comfortable and more kind of in charge of who we are in our mind and in our body. And we've got the opportunity to explore other erogenous and arousal pathways that can benefit us, as Susan and her partner so beautifully demonstrated. And I love this. It's in aged care, but it's a beautiful film called The Heart Has No Wrinkles. And we often, the thing I love about Susan's story is that often as health professionals, or often we think when we're bombarded by those beautiful plastic images all the way around us, that if we don't look like that, if we don't act like that, then we're pretty much, our sexuality has been kind of written off by people around us. So I don't need to tell any of you that's been going through the treatment, or if you've finished active treatment, that all of these, side effects of treatment have the potential to impact how you feel about yourself as a woman and as a man. In fact, we know that from the moment you hear the words, you have cancer, whichever blood type of cancer it was, your life is forever changed. And we know that that happens. Often the brain can get locked in the trauma. People can remember exactly what was happening at the time. But the whole purpose of this talk is to allow the brain to flick the switch from the fear and the shock and the uncertainty and the whole use of acronyms and the strange language that we got bombarded with, to deal with things like, most of us haven't heard of the word mucositis. Most of us don't even know what coital and frequency and, that kind of libido status is that we measure as health professionals and as scientists. But we know in summary that there's a lot of changes that can happen to us physically, but as well as mentally, with all of those, that list there. Sexuality and intimacy obviously affects men in a very similar way. And it's fascinating that in my own research that a lot of men felt that when they gained weight, there was a big perception in the cancer community overall that I thought I was supposed to wither up and die, inverted commas, they used to say to me. And here I am, I've got so much extra weight and extra fluid on board as a result of my treatment. And I feel repulsed by it, or I feel that I don't know how to overcome that when I'm given steroids that are increasing my appetite and things like that. So there's a lot of issues here, both physical, mental, emotional, and sometimes existential, that can impact how we feel about ourselves and how we can navigate the renegotiation process that Susan and her partner were able to do over time and place. So in summary, and we know that this is broad brush information, and I can go into more detail if any of you have specific questions, but overall we know that chemotherapy can often, depending on whether as women we're pre or postmenopausal, depending on the age that we start our chemotherapy as men and women, that it can have a dramatic impact on our desire, which is controlled by androgen, one of the hormones in our body. So because of that, and sometimes people say to me, it's really important that I know that there's a hormonal reason for having just a low interest in sex, apart from everything that I'm managing, the uncertainty, the frequency, the roller coaster of, blood tests and checks and investigations done. All of that, of course, can increase or reduce the desire. But we know now that chemotherapy can have a specific reduction in how we pleasure ourselves and how we get out of bed and how we even feel that we hold our body, as well as our interest in penetration or any form of sexual expression. It's really important to note, though, that everybody is unique. And the whole reason that I got into this area, I was a cancer nurse, as Jen said, and I was working on a chemotherapy unit at the Royal Melbourne Hospital at the moment. And I was doing my nighttime round, and I had never thought about sexuality up until this night. And I was checking and fluffing everyone's pillows, and I was checking their chemo. And I had just literally moved this woman's pillows into place, and I was checking how much fluid was in there and what time the pump was going to go. And she called me over and she said, "Hey, Amanda, is it okay to have sex when I've got that going through me?" And I was so glad that the torchlight was on her face and not mine, because I was like this. I didn't really know how to respond. And my mind was imagining why she was asking this. And I was thinking back to the day before she was vomiting profusely on this very high dose chemo. And I said, "Look, I'll have to get back to you about that." And she said, "Oh, don't worry. We just had sex in the patient lounge while you were all in handover." And I swear to God, I did not know how to respond. I didn't know whether to say, "Oh, that's great." And I'm kind of imagining the positions of how she would be holding that drip pole, and, how small the couch was and how they could possibly have done that. And I said, "Look, I'll get back to you." And I went to the nurses' station, and one of my colleagues said, when I said this story, she said, "Oh, that's so gross." And the other one said, "Look, we should really be locking that patient door, that patient lounge door in handover." And one of the doctors then, because this is in the old days before Google, he said, "Look, I don't know the answer to this. I'll have to ask the consultant in the morning." And I said, "Well, it's too late. They've already had sex." So some people, and when I asked her ages later, it was about another chemo cycle later, she said, "I just wanted to make sure everything was working. It was a fairly new partner. I didn't want to lose him, miss him, but I just wanted to make sure everything was still working down there." So what we often are trained to teach, as what my answer should have been, is, look, it's great that you ask, and what perfect timing. Would have been good if I had have told you this before we put the IV up and the cannula up. But it's a good idea to wear a condom for your partner if you happen to have one, or wear a dental dam, have a dental dam if you're going to have oral sex, because we know that chemotherapy is excreted through blood and body secretions, which includes vaginal secretions and penile sperm and penile secretions. So because of that, we were talking about this before you all joined in, we were taught as health professionals, double flush the toilet. There's no basis to this except that we know that it's just to get rid of the urine and the feces, which could have the chemotherapy. So I'm not quite sure why we had to do that down a toilet, which is already flushed away. But I now know that I should have said, look, perhaps next time, should you be interested, get out that dental dam, which is just like a latex square, and place it over your vulva area if your partner wants to go down on you, just because you're also immunocompromised. Your blood cells, your white cells might not be up at the moment, and it will protect you from having any exposure to infections that you may have had in the past, but it will also protect him or her. And Karen Phelps, when she was the head of the AMA, wrote in a great book, Sex, years and years and years ago, decades ago, she said, she feels like she's getting her patients to dress up for Mars when she says, to put on the gloves and the dental dam and double flush the toilet. So we know that some people are going to have the interest or the desire, and some people just want to make sure that it still works. We also know from radiotherapy that with the fatigue, often it's just not in the equation right now. But often it will come back as just a marker or a milestone that people want to go back to doing what, as Susan said, what we connect to as a couple, or people want to go out and start to explore new relationships, which we'll talk about in a moment as well. So most of you know that when you've had radiotherapy, or you know somebody who's had it, that these are all of the issues that can be flagged for you. And so often you think, well, that's a good reason to just not put sex on the calendar. But remember what we said before, that, you know, if we could put genital sex off to the side for a little bit, one of the important things, which we're going to explore, sensate focus technique shortly, is just to reconnect with the now body rather than the other body or the old normal or the past normal. It's just starting to reconnect with the now body. And even if there are bowel problems, even if there are irritations or incontinence of any sort, but we need to be able to dispel myths. And one of them, I know you probably won't believe this, but I did get asked quite a few times when I used to work on the cancer helpline about whether you're still radioactive as a result of, you know, full body irradiation. And I think these are really important ways that you can actually talk to your doctor. But the answer is that while the active treatment has been ceased, that even though the skin mucosa is still getting very sensitive and irritated, that there's nothing stopping you if you've got a desire for it, and if it's something that you want to initiate and reconnect with, that the body will usually tell you when it's a safe and good time to do that. And we'll talk more about that in the question time as well. Just very briefly, this is a huge area, and I was very privileged to work with Professor Jane Usher again to produce this book as a result of real data that came through that we know. So it's available at the Cancer Council, and it was written in response to what do people like yourselves want to know in relation to fertility after cancer. And so we know in very broad brushstrokes that it depends on your age of when you start the chemotherapy, and the type of drug that you have and the cumulative dose. And all of those factors contribute to whether you will be premenopausal and go into postmenopause, or whether you'll become infertile as a man and as a woman. It's a fantastic resource, and it just got an award for being a very good patient-centered book internationally, because it came from people like yourselves asking the questions and getting the answers as well. In that book, I spent probably a third of it trying to talk about when menopause comes early. It's like one of the women said there, it's like I've, you know, I'm feeling older in my body than my mother. She hasn't even had menopause, and here I am, my body's defied me. So we know that when menopause is exacerbated by treatment, through chemotherapy, through ovarian ablation, of radiotherapy and or chemotherapy, or through putting and holding off and trying to preserve ovarian function. It's a whole big area we can talk about in question time if we want. That often we believe, because we don't know, do we? Because each of us are going to have a unique menopausal profile and experience that we don't understand until we have it. But our belief is that when it's brought on early, the whole body gets kind of abruptly into this state. And it's like the ovaries and the pituitary gland don't get a chance to, as the ovaries usually gently wind down, we start to then produce other types of getting small amounts of estrogen in our body in a natural menopause, whereas when it's boom, like that, it's switched off, we can have sudden exacerbation of these symptoms as well. So in summary, most people will say, am I normal? You know, weight, it's terrible for my self-esteem, says one woman. I just haven't got the energy. I just can't even think about sex. When I went up to ask him about it a couple of times, this was a guy with myeloma. He didn't give me much information. This was his GP. He sort of made it out. It was a bit of a joke to have a 70-year-old asking about sex, and I just couldn't get the information I wanted. So he had the guts to go and ask, and how do other people cope? I told her what's happened to me, this friend, and this woman said, my friends had this same induction therapy. It probably wasn't the same, but she told her it was the same. That's all I wanted. Somebody alive in the world who could speak to me and tell me that I was going to be okay. A lot of the psychological trauma and the burden and the uncertainty, I just keep thinking, why me? What have I done to deserve this? So often we have a lot of this going on in our mind, and then we wonder why we're not aroused, or why we're not feeling intimate, or why we just don't have the energy. It doesn't change much. I can pretend to the external world that I'm going to be okay, and one day I'll believe that, said somebody more pragmatic. And this is a beautiful, real quote. All of this came from my research. I love her, but she's so thin and sick. and I'm frightened to make love to her, whatever making love to them means, in case I hurt her. And I thought about that quote when my mother was in fact dying and she was in a palliative care hospice. And she was the mother who said, I'll get back to you about that. And she never did. She was the mother who did grab one of my vibrators and I never had it returned either. That's another story. Remember that she actually said to me at one point, she'd only been married for 8 years, and she said to me in front of me, she said to her partner, Steve, I just want you to get into bed, get your clothes off and just hug me and hold me. And that was within a week of her dying. So I got out of the room really fast, gave them the time to just hold each other. And this came from one of your pre-session questions, which was, I know I should feel lucky to be alive, but I just want to live fully, and I want to live fully and be intimate and confident in all aspects of my body. And that reminds me of a beautiful young man who had AML. And he said, what do I want? What do I want you to tell the health professional world? I want to deeply connect with people intimately and sexually from the moment I'm born till the moment I die. I don't care about prognostic indicators. I don't care about anything else. I want to deeply connect with others. And so I get a lot of deep messages in my clinical practice now. But I also know I used to be one of these health professionals leading a team at the Cancer Council. Rah, rah, rah. I'm just checking my time. It's your responsibility to raise the topic. You must raise the topic. You must tell your patients about this. And I used to stand on podiums and say, if you don't do it, your patients will never have the courage. And then with my research, I started to understand, which was one of your questions, why don't my health professionals raise it with me? We just said 15% in the poll that was taken before here had the topic raised. Well, this is what happens to our health professionals. Surely, some of the health professionals think surely they've got more important things on their mind, or I've got more important things to raise with them. Often they would say to me, look, I pretty much avoid the topic because I'm assuming somebody else will address this. And this is not the time and place. It's so public, it's so embarrassing. And basically they're saying, I struggle when they're older. I struggle when they're sicker, when they're the opposite gender, if they come from another culture. And one very brave young Italian doctor said, I can't even talk about sex in my own life. And most of my patients walk in the door looking like my parents. There's no way I'm ever going to raise that topic with them. And as we have understood in the literature, in health professional literature, it's about, just as with you living with the cancer or being a carer of somebody, coming to terms with what does sexuality mean now and how do we want it to be in the future. It's pretty much the same with health professionals. We have to kind of recognize what it means to us so that we can stand aside from that and really listen to who you are and what your concerns are there as well. So the big message then for this is that we often know what we should do, but as a professional, we often just get in the way of ourselves. We avoid it, hoping to show that somebody else has got better skills, better training, better education, better life experience, and that they're not going to put a foot in it as well. So like your literature is really saying, what your polling data is saying, the patients or the people like yourselves are saying, if it was important, you would raise it with me as a doctor, nurse, social worker, psychologist, psychiatrist, GP, faithful allied health professionals, physios, or if it were, they would raise it with me, but it's that mismatched expectation. And usually it's just not dealt with at all. So what we're just looking at now, just briefly, is that there is a sexual anxiety. So when Susan mentioned that my husband was going through his own anxiety, which was existential, I'm sure, or the whole uncertainty of a life, limiting possibility here. When you put all of that aside for a minute, even the people who come to my clinical practice for sexual health and well-being worry about, will I stuff it up? Will I put my foot in it? Will I embarrass myself and or my partner if I happen to have one? And nearly everything that we do in this kind of work goes back to old stuff that's way before the cancer experience, way before the adult experience. And there was a wonderful woman who taught me counselling decades ago in England who said that 90% of your issues, your clients' issues come from the past and 10% of them come for today. And I was like, yeah, I get this, but I didn't get it until I went into this conscious and unconscious mind. And I'm just going to mention this one more time. I won't blab on about it, but penetration and orgasm are the benchmark in satisfaction in nearly all sexual health literature, in nearly all research. So it's like that's the most researched area. And an article just came out a couple of months ago from one of my esteemed colleagues in the Netherlands who was a sexologist for decades. And he said that we're still just measuring orgasm and penetration and capacity to do that. And he said he was quoting the renegation strategy, that we've got to do a lot more than that. So what are we going to do about this? Well, one of the first things is just to be aware that our mind plays a big role here. And this brilliant man, Dr. Joe Dispenza, is a neuroscientist, and he wrote this fantastic book that I love, Breaking the Habit of Being Yourself. And he said that every day we have 60 to 70 thoughts that we're not even aware of. We get out of bed the same way, we wash our teeth the same way, we get dressed the same way, we jump in the car the same way, we attend our doctor's appointments the same way. We do all of these things each day, and it's nearly always the same way. Cue, trigger, response, cue, trigger, response, operating in automatic pilot. And all of that's okay unless we are aware of some of the thoughts that get in our way of our sexual health and well-being. Now, Mahatma Gandhi couldn't have said it better, because if we're not able to not only recognize the thoughts that don't serve us in sexual health and well-being, but also how to override them, then they start to control your destiny. Your thoughts, your beliefs become your thoughts, become your words, become your actions, become your habits, become your values and your destiny. And it's a really important thing, because it's what I've learned in clinical practice that I didn't learn from counselling, I didn't learn from nursing, I didn't learn from leading and teaching, and I learned it in clinical practice, that unless we can get rid of the what if I'm no good at sex, which usually goes back to worried about getting people pregnant when we're young, good girls don't, bad boys shouldn't, don't want to get an STI, don't want to be caught, or people who have been caught when they were young people are still worried about being caught or being seen as sexual, and what if I disappoint my partner? The two biggest questions that come up in general health and sexual health and well-being. So we end up like this, or we end up like this, and never the twain shall meet. Excuse me, that they're just heterosexual images as well. So the book, which actually Jen mentioned, is not just a PDF, it's actually a hard copy book that I'm going to give you a link to at the end. But I finally spent another 15, 20 minutes after 20 years after my PhD to work out that if we can reset the brain from fear, false expectation appears real, to override, because we know with any change in our life, that courage isn't the absence of fear, it's just knowing that something is more important. And that's what Susan was saying when she said we wanted to enjoy, we wanted to make time. And these are the questions, if Susan had come to my practice, I would have asked her, what are your top 3 goals for enhanced sexual and intimate confidence? Now, that's if they booked in with me. But when I was working on the cancer helpline, I never even mentioned the word sex or intimacy. I would have asked and said, look, how has all of this made you feel as a man or as a woman right now? You've talked about a lot of things. And what is it, the one thing that you want more of now that you didn't have at the beginning of that consultation? And I now understand that unless we connect you, each of you and each of us, to a why factor, once we know why we want to make one change, even if it's a little micro change in a better direction, even if it's just resetting from fear to fun, or fear to joy, or fear to just something other than fear, if we know why, then I know now that there's a lot of research to show that our mind and our body will find a how. So where are you now, and where do you want to be? And so I ask people, what specifically do you want? Because we want to remember that it's not just about penetration. It's not about orgasms. It's not about whether you're having oral sex or using a dildo or a vibrator. It's not about any of that if you don't want it to be. But what specifically would you want if we could wave a wand? And how will you know that you've got that? What will you see? What will you feel? What will you know? And I know it sounds strange, but I always get people to close their eyes when they're thinking of their answers so we can block out the world. And one woman just started gently just wriggling her hips when I asked her that. And she started just having a little smirk. She had a bald head. She'd taken off her wig. Too hot, and she just started having this smirk, and I said, oh, you don't have to share with me what you're doing, but something's helped you flick from where you are to where you got to. And she said, I'll be playing my favorite music, I'll be in the kitchen, I'll be making pasta, and I will be starting to dance in a sensual way, and that's when I know that I'm coming home to myself. What outcome will that allow you to feel would be another question. So going back to another question that Linda passed on that you'd asked was, how do you open these conversations with your treatment team? So I'm out there banging on to people about it's their responsibility and overcome your own taboos and assumptions and attitudes, beliefs, and really listen to your patients, your clients. So some of the questions that you may like to ask, and I've got many more written in the book, of course, which is, how will this treatment affect my sex life or my sexual health and well-being? Is it safe to have sex again? Sex is uncomfortable. I don't know how to manage this. Are you the right person? Is this the right time? Is this the right place? How do other people cope with this concern? Maybe something. And I always implore people, and we can go through these issues at the end because we're going to have a really good question and answer section. But I always, on the helpline, even in a 10-minute discussion, I used to say, let's write the question down now and have a gap after your question. And even you could email it to your clinician if you know their clinical address, or come in, print it out, come in with a spokesperson or a person that's going to listen to you and just write down and be your scribe if you have that opportunity, and just walk in and take control and say, I've got 5 questions that I want answered by the end of this consultation. Do you want me to answer them now? Do you want to look at them now? But I don't want to leave this session until this consultation until you've answered them. So some people feel better emailing them or preparing as they walk through the door, or they'll just fling it to their health professional, and health professionals really, that helps them guide the discussion. But one of you said what kind of health professionals which we're going to look at the end. There's a fantastic group of, so obviously your GP is a good trusty friend if you've got a good relationship with them. Oncologists, you know, people that are actually working with you as hematologists, people, cancer nurses are wonderful, of course. You know, that often you'll find your person, as did Susan, who actually asked her the question and then gave her information. But what we really, so we'll come back to those practical people that you may consider that there's even more out there as well. So the very first thing that I do to shift you from fear to something better is just being aware of getting out of the head, the talk, the chatter that is just holding you back on a conscious level, and just start to give breathing techniques, which I've got right at the end of the talk to share with you about how to close your eyes and just allocate the time. The beautiful Susan and her partner said 5 minutes, 5 times a day. We just made time to hug each other. Once a day, we went into the garden, and I would, if she didn't have a partner, or if you didn't have a partner, I'd say just to close your eyes and allocate 5 or 10 minutes a day to get comfortable with the physical, the ports, the body, the change body, the tired body, the exhausted body, the shocked body, the trauma body, and start to befriend the body. And then have a go yourself. And I'm going to talk you through all of this as well. And to rebuild sensual awareness by actually putting sexual intercourse off bounds for a while. And I've got like a 6-step process that I take you through in the book, which is really just saying, okay, let's put penetration and orgasm aside as a benchmark for a while. And let's come back and befriend the body and start to work out what feels good with different types of lube and different types of sex toys, or different types of you know, sensations and textures with silk or satin or feathers or anything else that may take your fancy. And what we're really trying to do is we're trying to explore your sensuality. We're trying to get you out of your head, because in my world of hypnotherapy and brain retraining and neuro-linguistic programming and neuroscience shows that if we can reset the mind to a better place, the body starts to follow those cues and triggers. And you won't believe this research, but this wonderful woman who actually looked a little bit like Susan, she was very articulate, very academic, very eloquent in her speaking. And she stood up at this World Sexology conference. She threw something onto the podium, but she wasn't quite as spunky as Susan. And she had thick brown stockings and thick lace-up shoes as she walked onto stage. And we'd all probably written off her. And she threw this thing on the stage and she said, right, I'm going to teach you all about orgasm. And we kind of all just sat up in our seat and went, oh my God. And she did. And she showed MRI scans of people having full-blown orgasms when they were just having thoughts. They were just having thoughts and revisiting memories from there. I'll come back to that in a minute. When they were having thoughts, and they were starting to revisit fantasies that they may have read about, or that they may have wanted, or they may have lusted over in their life. And so she showed that the neuroscientists couldn't tell the difference between people who were having full-blown orgasms just in their mind and the ones who were arousing themselves with vibrators or with manual stimulation. I mean, I've never participated in that kind of research, but people do it. So the neuroscience couldn't tell the difference between the ones who are imagining it and the ones who are actually doing it. But Susan actually also, I'm just flicking around here, mentioned some beautiful things about lubrication. And so I often get people to start to reset the mind. What do you want and how do you know you have it? And have you got a fantasy or an arousal kind of pathway that you usually work for? And would it still work, or do we need to help you find something better? And then the next thing is, as Susan so beautifully said, it's really helpful, even if you've never used lubrication or never thought that you needed, inverted commas, lubrication. Lubrication just becomes a beautiful kind of way that the woman at Passion Fruit that I'm about to show you, who taught me everything that I know about lubrication and vaginal moisturizers, said to me when I walked in and I said, I want the latest in lube, probably 25, nearly 30 years ago. And she said, what's it for? Which is a really good question. And I'm going to send all this to you in a lubrication matrix. The first question to ask is, what is your use? Is it for day-to-day comfort? Well, you probably need a moisturizer. Is it for orgasm and masturbation? Is it for dildos and toys? Is it for anal sex? Is it for penetration? So is it to be in a shower if you're incontinent? Is it? So ask the question is, what's it going to be used for as well? And all of these lubrications that I'm mentioning that I developed a matrix, they're all pH friendly, and they're all paraben and glycerin free. So they're not going to affect what goes on down there for men and for women. One guy who came, and I said he was an old guy, he was 88, and the best thing that he said to me, it wasn't any of my wisdom, it wasn't helping reset his brain, it wasn't doing phobia techniques to get rid of old trauma about being bullied and rejected by women in his past. It was the free lube samples that he loved. And I said, go and have a go at yourself. And he goes, oh, what do you mean? In the tool shed down below? And I said, yep, you go right back there to the tool shed down below and try and have a go yourself. So Passion Fruit is a beautiful resource. I, in fact, just did a big recording there about how to walk into a sex shop. So I do have a course that's just become available. And step 8 was, how do you walk into a sex shop? Do you take a friend? Do you have a drink first? Do you have a shopping list of what you need or what you don't know? Do you have an agenda? And how do you know when you leave that you've got what you came for? How do you find a reputable and reliable and evidence-based place? And Michelle is amazing, and she still teaches me all of what's really important here, and all of these images and things came from her website as well. So a lot of, just to kind of finish off before we open the question time, a lot of what I'm really teaching people, and I spent a whole chapter on it in my book and a whole segment on it in the course that I did, which is just a step up from the book, is the M word. And when I bring up masturbation at health professional conferences, most people blush when I walk towards them in the lifts or in the elevators, and they kind of just divert their eyes. But as Karen Phelps said in a survey poll that she took with all her patients when she was working as a medical practitioner, she said, well, 96% of my patients have admitted to masturbating in the past, and the other 4% are liars. Because masturbation is whatever you want it to be, and it's probably the most reliable and evidence-based technique for sexual health counsellors to use to help people get out of the fear in the brain and reconnect to the now body. And so often we get people to explore sensual pathways, to look at the body and the genitalia first week, sex out of bounds still for now, second week to start to stroke areas, non-genital areas, and start close the eyes and work out what feels good and what doesn't feel good, so you can start to have a voice and set boundaries. The third week, it's usually starting to explore down there if you want to, just playing, just rubbing, just feeling. The fourth week, it's, do you want to add a vibrator or a soft pillow? And there's this beautiful liberator range for people who are incontinent or just want a little bit of a pelvic lift. We'll talk about that later as well. The week 5, it's like, okay, if you want to go for the big M word, the masturbation, the orgasm, some people have never had one of those. Some people never want one of those. And week 6, it's usually, okay, where are you at now? What have you learned about your body? Are you ready to invite a partner, a prospective partner, or a future partner into your world? And if you are, we're just going to go back to, how do you be single and have sexy pickup lines? And when I was writing this book, I sent it out to a lot of expert reviewers, and nearly everybody wanted to know, how do I have pickup lines full stop? So these are some of the ones that my patients, my clients have taught me. Before we go any further, I just want you to know, I had cancer some time ago. Before you go any further, just the treatments left me with or I just want you to know something. I've had a shit year, you know, this has happened, and I haven't had sex since I had the cancer treatment. I do want to take this further, but I'm not sure how I'll feel now that I've had the treatment, or now that I'm in the midst of my treatment. That's only a few, there's more in the book, but when I've run workshops and seminars about that, the biggest, most important and powerful message comes back to you feeling empowered back in your body. So when people keep telling me, how do I get a partner? How do I tell my partner's going to reject me? I'm worried about my partner's anxiety. I always get back to just how, you know, how self-esteem and confidence, how would you as a man or as a woman feel okay back in your body? What would it take and what would you do? Start with you and then invite the door to intimacy, because we know that then it's a good chance to review the quality of relationships and to have fun along the way. And I love this quote just before we open up to questions, that laughter is the shortest distance between two people. And some people have a look at that picture of the couple in the bath that I just showed you, which I have to thank Reese Plumbing for, and they will say, oh, but the bathroom floor will all get wet and saturated. And I go, that's okay, you know, have lots of towels, get into the bathroom, have some fun with it, and because you can always count on yourself. So by then they would have started to look at new arousal pathways. The really important message that I want to end on before we get into just the question time is that many of the people who were having orgasms because they participated in the research were people who were deemed by health professionals, scientists, doctors, you know, researchers, to not be capable of having them because they had spinal compression, paraplegics or quadriplegics, for some of the group that this Professor Beverly Whipple did the research on. And the body cleverly found a new neurological pathway. So the spinal cord was severed, but the brain and the body worked together because the person wanted that, and they worked on it and they retrained their brain, and they started to imagine old pathways. They started to imagine old fantasies, old erogenous zones, and they were able to spark desire and arousal in bodies that were deemed impossible to do that. How did they do that? Their very clever vagal systems started to kick in and create that as well. So just before we go to questions, it's about, if this is important to you, only if, and I assume it is if you've logged on to this fantastic forum, just like Susan did, making it a priority. So you hug each other 5 times a day is a beautiful strategy that I often get people to do. Holding hands in their garden. Gardens often represent new life and a deep shared connection. For other people, it may be dancing together, breathing in together, and breathing out together. For other people, we'll be listening to beautiful music that used to connect them and used to connect the spark. So it's setting the time for when you're not exhausted and putting it as a higher priority rather than last thing at night, and experimenting with new positions. Just knowing that from decades ago, we know that the greatest discovery of our time is about, if our mind perceives something, our body starts to believe it, because our body is a robot controlled by the mind. So just before we go into question time, there is, you know, a considerable amount of support out there. It's fantastic. I just so commend the Leukaemia Foundation for running this event and recognizing in response to your needs that once we make it normal and validate that it is an important topic, that then it's linking you to the right information at the right time. So obviously there is a book that will be for sale on my website, the Dr Amanda Hordern, and I can post it out. I think it's going to be a bit cheaper that way, other than Amazon, where I think it's up. Amazon changes its price all the time. We can talk about that later. The fantastic Cancering Council sexuality book that I wrote, the first one way back in the 90s, and then it keeps being edited, but also the fertility booklet, that's a wonderful resource. And just before I left the Cancer Council, I put in place, and it's still there, I checked with some nurses I was speaking to on Saturday, that there's a psychosexual help line that you can call 13 at 1120, speak to a nurse. They'll put you on a waiting list for all around Australia. There's these, it's only once a month they come into clinic, but they talk to you on the phone, and they're doctors with psychosexual background. I also looked at spoke to one of them who used to do that, but she doesn't do that now because her practice is so busy. And we in Victoria, we're lucky because there's a couple of public places, Royal Women's Hospital and Monash Medical Centre, that run sex clinics that are free. But of course, sadly, there's 9 months wait for those. They're free, they're worth the wait. They're medical experts who will observe, you know, the vulva or speak to you about erectile changes that may happen, remembering that 40% of erectile problems are up in the head and the rest may be from treatment induced. But the great group that I just power and just, you know, rah, rah, rah about are pelvic health physios. And they're a big expanding group. They're a physio, but they've also got to have additional training in pelvic floor. They specialize in sexual health, in incontinence, in, you know, erectile problems, in something called vaginismus, which is like the spasming or the painful sex. And I'm very lucky because I've got a group of them only a street away who they often say, look, mechanically, we've worked on this person and they're great mechanically. So over to you now to reset the mind to a better place. And I quickly looked up this ASSERT, Australian Society of Sexologists, to find a practitioner. And there's some great GPs that have also done psychosocial or psychotherapy in sex as well. So I'm going to stop there, Linda. I did my best to keep to time, and just because I can see 17 questions, so I'm hoping there's some great questions. I've tried to skim through really fast, but this is the bit that we're all waiting for, to be able to make it really tailored and individual in my responses. So I'll put it back. Do you want me to stop sharing now?
Yeah, that would be great. Thanks, Amanda.
And I'm going to send this talk to you all and send the lubrication matrix that I've got out of the book, and send the link for anyone who wants the book or the course as well. So I'll just stop here. Thank you very much.
Fantastic. Thank you. That was amazing. Amazing. So much information, and the comments are just starting to really, I think, as the audience has absorbed the information and processed it, I think the questions are starting to really come now. And I actually just want to comment firstly about, I think it sort of really reiterates what you've said, your message, Amanda, from someone in the audience who said, our body is a robot, so controlled by the mind. And it is so incredibly true. Thank you for Afalabi in the audience for just reiterating that.
Tell Falabi, I didn't know that until I did hypnotherapy and neuro-linguistic programming. I'd never heard of that phrase before, so she's very clever, or
yeah.
she. But yeah, you're spot on. The body's a robot controlled by the mind, and if you think something, if you think you can, you're right, and if you think you can't, you're right. Henry Ford, So
yeah.
If we get this bit right, then our body's more likely to respond. So thank you for saying that here.
Yeah. And I think just one of the really clear messages is about, and I think is so promising for the audience and for people who are dealing with many of these issues, is the possibility that there is so much help out there. There is capacity to change, to have change, and to be much more inclusive of intimacy and sexual health in our lives. And it doesn't all come down to just the physical side of it. So there's so much about how the psyche influences that. So really love, it's really important to hear those messages. And I hope that is certainly reassuring and hopeful for the audience to hear that. I'm going to look at some of the questions and just share some of those with you now, Amanda. And a couple initially that came through fairly early on were around those who are in single relationships, and that is obviously has a different impact. So a couple of audience members have asked, what if you are single, not having those supports, let alone sexual intimacy, makes living with blood cancer even more challenging. And a couple of other audience members have really concurred and related to that person's comment.
And just flipping that to the other side, because I'm very good at flipping to reset the other side of that. And what I've learned from people who are single is it is a good, and I totally hear that and I feel with great compassion what you're saying, and I totally support you in that. But flipping to the other side, if you came to me or just spoke to somebody, I'm not trying to get you to come to me, but if you were saying that to me, I would, with great compassion, listen to that. And then once you finish with that, I'd say, okay, let's turn the page over. That's your current state. So what would you want? And as a person for yourself. So it's a good opportunity when you don't have partners getting in the way, when you don't have other expectations like poor Susan did. And I'm not discrediting with the comments, but it's like this is an opportunity to really come home to yourself and work out what works, what doesn't, what's aroused, and to do it in a totally immersed way that is only about you. And then to learn to have a voice, to express it. And then I can talk to you about the 5 languages of love or something like that. But to flip it to the other side, everything that I speak to people about in sexual health and well-being as an educator always comes back to you yourself. Yep. And then put the partner aside for a bit and then find the bridge. So I just wanted to say that it's a good opportunity, perhaps for some people, the first time in their whole life that they've given themselves permission to explore your body, what your heart wants, what you don't want anymore, and to feel or a deeper connection with your sexual body than perhaps before as well.
Great. I think that flipping it and looking at it from that perspective, like you said, I think we don't take enough time in our own lives to prioritize ourselves before prioritizing everyone else's needs. So taking that opportunity, and the one relationship we often don't work on enough is the one we have with ourselves. So great insights and advice. Linda, did you want to put forward some of the questions from the Q&A?
Yeah, we've talked a lot about the perspective of people with the blood cancer, and we've had a question come through about someone with a partner who's the partner of, who's having trouble bringing that conversation up, you know, and wondering sort of how to go about that, because obviously this sexual intimacy and relationship is very important to them. So how can they go about showing it in a caring way that is important to them and it needs to be addressed?
I'm so glad. So thank you to the brave person to raise that, because often the carer, the partner, is the hidden army behind all of this, and often feels invisible, or everyone says how's the person going, but never ask themselves. So I did dedicate a section to the book on how to raise it as a partner. But the really big thing is to, even before sex, is to build up some sort of intimate connection, if as a good segue into that. And that's why I love the walk hand in hand in the garden, and the breathing together. Oh, they didn't say breathing together, but my patients say, sometimes we just want to have a big hug. So assuming that you've started to have some ideas on how to do that, then it's often good just to start really small and just say, look, I know that you've got a lot going on at the moment, and I definitely don't want to put pressure on you, but at some point when it's the right time and when it's the right kind of place, I'd love to just have the opportunity to explore how we can reconnect to something that is just for us, that we don't share and dish out to everybody else, but just for us, because I really miss it, or they're the things that we used to love, and there's no pressure. So it's really just trying to say, and then if they get the permission to do that, because it has to have permission, and then listening. I always say to my clients, like, put the timer on the kitchen, bench or something, put the oven timer on for 5 minutes to just have a touching base with each other. How are you going? And it's half, 5 minutes each, 5 minutes for her, 5 minutes for him, 5 minutes for her, 5 minutes for him. So just trying to work out so that you're just learning how to communicate. How are things going for you in general? Because it's impossible to, well, I shouldn't say it's impossible, because that lady found a way that I told you about, Ange. We just had sex when you were having handover. But if you're not sleeping well, if you're dehydrated, if you have kids that are going through a horrendous time, if your parents are dying, if you've got all of these other external factors that influence how you feel about yourself and lack of time, then it's going to be really hard to say, I just want to, walk around the garden and hug each other 5 times a day. So it's trying to find the one thing that could reconnect us back. And even though it doesn't look like I can pause and stop. I would normally stop and pause. And it's just waiting for them to come up. And sometimes saying to the partner, look, why don't we try this technique where we just close it? I'm going to ask you a question. I want you to close your eyes, and I'm going to be really quiet because I know you're going to find the answer, or an answer. Any answer is okay. Of what's one thing that we could do again together that is just for us. And then what's another one, and what's another one? So that could be one thing. So then it could be setting up a hot date with yourself. If you almost put sex, remember what I've said many times. I said I wouldn't say it again, but it's more than genital and intercourse. So, but if you actually say that, you take the pressure off sex, because some women have said, mostly women, occasionally men, have said, look, I don't even want them to hug and kiss me because they want more. And so they kind of put the door, they shut the door because they don't want to be seen as coming on to their partner when they're not ready. So some people just, you know, if we can articulate that, that's a really big thing, and just say, look, if we just put sex off limits for a while, I want to remember, what did we used to do? Did we hold hands together? Did we listen to something together? Did we go for a walk together? Did we dance together? And then I would encourage them to have a date, even if it is taking a walk around the block or doing something where other people are occupied. I used to just groan and raise my eyes to The 5 Languages of Love by Gary Chapman. I must confess, I was in very much researcher mode. How can there be 5 languages of love? But after my 7th client suggested it, I went, okay, I'll shut up and I'll read it. And I was like, yeah, I get this. It's like trying to find the whole precipice, the purpose of the book is to find out what makes you feel that loving connection between each other, or for the person who's looking for a potential partner, between what makes me feel loved and what would a potential partner, how would they contribute to that if I get one? And so it's words of love, it's acts of service, it's quality of time together, it's an intimate touch, including kissing or hugging, or it could be gifts of love. So they've got free questionnaires online that you can do. And, you know, I was with a partner for over 20 years and I learned something that I didn't know about my partner. You'd think I would doing this sort of thing, but I didn't. And it's given me permission to go, actually, when this happens, it's the cue to put more energy in for that person. So it could be, is it okay to talk about it in your own time, in your own way? Could we put the timer on 5 minutes each to just check in how each of us are feeling? Turn off the phone, turn off everything other distraction. Could we go on a hot date together that doesn't have to be hot and penetrative? Could we do a 5 Languages of Love questionnaire? Could we do something playful that brings us joy? Are we having fun yet? So that's a long-winded way, but my book's full of it all, and other techniques on how to blink away and reset the mind. This is written for partners and for people with cancer as well. So I'll stop there just because you may have more questions that you want more time with. Yeah.
Thank you for that. That's good. I guess we've had another question that's come up that's a little bit more about, this is, some time has now passed and the foundations were set, but it seems to be maybe getting harder than easier. What about that time as it goes? You know, is there an expectation that things will have changed and will never return? And, you know...
Yeah. Very good question. So timing is a huge topic, and I'm glad that you brought it up. So thank you to whoever brought that up, because it all goes about the timing, like the timing of when do I ask my doctor, nurse, social worker, psychologist, when do I ask my health professional? The health professionals are saying this isn't the time, this isn't the place. Partners are thinking, oh, is it ever going to happen again? People like yourselves. So timing is a huge topic that came up in my PhD again as massive. And the answer was that it's individual and it's unique to every person. Sex means different things at different times of your life, and it changes, and it's an ever-changing lived experience. So sometimes when the gulf gets so wide that doors are being closed, that there's no communication, that there isn't an eye contact, like there's a bit of research to show that if we can lovingly gaze into our partner's eyes, or just gaze into our partner's eyes for 15 seconds, then we're going to have more relationship satisfaction from those that we don't. Now, it's really, the 15 seconds is a long time if you have a go with that tonight or today, but it's like just trying to find other ways to intimately connect that takes the pressure off genital sex and just rebuilding the connection. So you know, doing some of these techniques, you know, maybe reading a book or going to a health professional that may be able to help you reset. Because what I said to you very quickly, and I know I've spent an hour just doing that talk about conscious and unconscious beliefs on the weekend, where even if we're aware that we've got this block, or that I think I should and I must and I better, or the fears of losing a partner, the fears of being seen pushy, the fears of making their cancer treatment worse, the fear of being selfish when they want to intimately connect. Even when we recognize that we've got those, it's often difficult to get rid of those fears ourselves, which is why I wrote the book, for some practical ways to not only recognize attitudes, beliefs, and values that hold us back from that intimate connection when time has passed, but also to then do maybe the course or something that just helps you step through, okay, I've done that. But there's nothing wrong in asking for help. And sometimes it just takes a little bit of help. Like I say to people, I'm a bit like the sports coach for your mind on the side. You're in there, you're immersed and you're absorbed and focused. But my goal is to keep just resetting the mind, not from fear, but back to fun, fear to joy, fear to one little micro step. Confucius said that every journey of 1,000 miles begins from one thought after the other. And there's a beautiful quote that I absolutely love. I just want to add to that, and then I'll shut up again and let you ask the next question. But it's written in Julia Baird's Phosphorescence on Awe, Wonder, and Things That Sustain You When Your World is Dark. And it's written for women, but it's a beautiful quote I've read to men, and they love it. There's nothing stronger than a broken woman or man who has rebuilt herself or himself. In Japan, ceramicists repair broken pottery with gold, with silver or platinum. It's a process called kintsugi. They do this to make a fractured object more beautiful than it was before, to honor the cracks, to dignify the scars and not hide them. And the possibility of death is there for each and every one of us, locked up in all of our moments. But so too is the possibility of rebirth, or at least revamping. And I love that because it goes back to that resetting, that we can stay in the horror and the shock, or we can choose this time to reconnect, as Susan beautifully did, or we can reevaluate our relationships and think, is this working? Was it ever? Is this my good out? Can I do a different route out of here? Because I've worked out that this ain't going to survive. I've confronted my mortality now, and I want more than that. So it's a big answer to a whole continuum of expectations, but it goes back to those questions I said. What specifically would you want as one step forward? How will you know that you've got it? What would be one first step that we could do? And is it about letting go of beliefs and attitudes, or is it about having a go yourself? Or is it about finding the time on the joy that you used to like about that person 50 years ago? You've forgotten what that was now. Or is it about just letting all of that go now and working out who you want to be and how you want to move forward independently of the relationship? So yeah, I'll just pause there and let you ask anything else.
Thank you very much. I think that was a very clear answer for that person, hopefully.
Thank you.
The other questions that we have, just some questions about, I guess, using supplements to help. So, I know you talked about passion fruit, was it? Just some questions we've had around those sorts of things. Like, if you've never done anything like that previously, do you have recommendations about how to go, and get some help with that sort of thing, or what you should be trying?
It's really good. And I love that question, because I'll just start with the story that I said about just getting the guts to go to a resource. So I was lucky because I've found that sex shop, but I've built a relationship with them, and I trust them. They're evidence-based and they keep me up to date, and they are online, and it's national, obviously, and I'll send you stuff in an envelope that doesn't mention passion fruit sexuality shop on it. But so that was my own research and having the guts to walk in. But I was forbidden from going to sex education when I was young, so I never used to find this comfortable, and I feel like I'm paying back my mum for the rest of my life. I'm speaking about it now, that it's really important. But it all goes back to just feeling okay about yourself. And so that's why I always say take a support person, to a doctor, to a nurse, to your appointments, because we know from the cancer research that only 25 to 30% of the information is absorbed when you've got this plethora of words and acronyms and trying to make sense of them on the run. And that person can listen to it. If you can record the session, even better, because then you can go back and go through all the facts. But then going to, I think they may be alluding to maybe testosterone patches or other vices to increase your libido. It's interesting. I've just read the paragraph in Norman Swan's book, So That You Think You Know What's Good for Your Health. I think it's got a big apple on the front. And he's got some really interesting, because it's all evidence-based, it's just got published this year. But basically he's saying that if the mind is in the way, the body isn't going to follow with testosterone patches. It can be good for a bit. But we know from that funny cartoon where women's arousal centers are all over the body, and so are men's, obviously, but we're being culturally shaped to believe that men are through the penis and women are through other erotic pathways. Men love to know that they've got 10 fingers and a tongue if they cannot get an erection. They love to get facts on how to give great oral sex. They love to know how to do that if they've never had those opportunities to explore those things themselves. So it's a wide question really to ask, but the Norman Swan take on it is that it takes more than a tablet to reset the mind if the body's still blocked, and that whilst that's why, you know, female Viagra and female Cialis often aren't working in the way, because we can have a tingling vagina, but our head will be still pissed that the rubbish hasn't been put out, or that they haven't offered how can I help you most, or they haven't gone into the language of love, of quality time, or an act of service, or a beautiful card or something like that. And interesting, just summary. So it's an interesting read. I don't know how much of it's online to be able to get, but there's a lot of clinical trials just saying that even men, and the drug companies aren't going to want me to say this, but when I spoke at the Prostate Cancer Foundation conference, it's being filmed for the end of this week, I had to really look into this, because they push, Cialis and Viagra and injections and pumps and devices. And that was one of my video recordings that I did in a sex shop. What's the greatest and the latest, and how do you choose the difference between that? And is a cock ring as good as a penile pump, and all those kind of things? Can you use it in the shower? Can you use it in bathtub? Blah, blah, blah. So once again, I went to a reliable source, but if women are in heterosexual relationships, they're like, we don't want the injections. We want to be held. We want to be touched. We want to be hugged. We want to be kissed. I don't want to have to wait and have that broom handle pushing into my back for another 12 hours. And what were they thinking with Cialis lasting 12 hours? 12 minutes would be too long for me. The average time of sex is under 5 minutes, for actual ejaculation. And so it's going back again to, it's probably too long to answer, but what is it that you want now? Not what you used to want, but what is it that you want now? We live in a pharmaceutically driven world where, there's a beautiful book called The Body Keeps the Score by Dr. Bessel van der Kolk. And he's got an institute of trauma in America. And he said that when he started training, he knew that the body and the mind are inextricably linked. And he's a psychiatrist. And so that we know that every one of our patients has the resources within them to reset that. Then he said drugs came in and we thought, great, we don't have to do that. Let's pop a pill. And he said now at the end of his coming up to his retirement, he just said that in the end, we need to go back to our bodies, go inside. And the only way to do that is through breath, through yoga, through awareness, through mindfulness, through just time alone, to come home to yourself in the garden like Susan, holding hands, hugging like Susan and her partner, to work out and befriend who we are. In order to let go of the trauma of the past, we need to go inside to do that. And a pill's not going to do that for us. So it's a beautiful book to read. And a lot of it is the kind of stuff I do in practice. So I was thrilled to read that as well.
And someone has asked, and I think we might ask you to just share your screen again, Amanda, that had some of those contacts around where to find a sex therapist or a sexologist, because there's a lot of questions coming through around communication, around raising the issue, and that fear of, when our sex lives have changed drastically as a result of blood cancer, the fear of what that means in terms of partners leaving, what that that really deep fear of loss that may be experienced. In terms of counselling and what can people, as a counsellor yourself, Amanda, what would you say are the sort of the key benefits of coming to see someone and talking through some of these issues that they might be experiencing, whether it's themselves or together as a couple.
Yeah. Well, I think sometimes it just takes the pressure off each other. So when you've got so much going on and you haven't got the time or the inclination, or you're finding that life's getting in the way of putting on the minute, you know, the timer for 5 minutes each, trying to set up time to have a hot date with yourself, you know, if you're struggling to find even the time to explore your body uniquely, then you may want somebody, because my clients say, well, I have to be accountable to you because each week you're going to give me something else to do and I've got to feedback with that. So sometimes that's a good reason to find the right person at the right time. And sometimes they're online sessions, sometimes they're face-to-face. But it's often hard to just get rid of the blocks that we are unconsciously aware of, but they just come pouring out of our mouth. So the book was a good step to approach that. And then the course is, you know, an 8-step program to do that. And but then there are other people around, you know, that can maybe assist you. And can I promise you, once again, I'll say it, that even if it's about keeping, you know, you're fearing that your partner's going to leave, fearing that, that, you know, you're only half of a person, fearing that you'll never be attractive again, fearing that they're external fears. And we really always need to start with who you are now and how you want to be as you move forward. And another good reason to go to somebody is that it's trauma going through a diagnosis. You know, your whole world is shattered, and it's about rebuilding and reconnecting after you've made meaning with that. And often the brain will hold on to trauma or very, you know, huge, you know, high frequency kind of fear-based, worry, concern, uncertainty-based emotions until you've taken something constructive and useful from that experience. So what I've learned is that a lot of being diagnosed with cancer can be very traumatic. And so I often do trauma techniques with people to just help them let go of all of the unknowns and put energy then into what is known and the things that are within your control. So sometimes I just say to somebody, okay, well, I've listed 20 of your things that you've just told me. It's getting in the way right now. And before we turn the bit of paper over to work out what you do want, I'm going to hand you back your list that you've just told me. And I want you to put a line through everything there that is out of your control. And inevitably a third to half of the list will be just have a line through it. And it's a very simple but very profound technique. But it's hard to always do that with yourself, which is why I get you to do it in, you know, the book and the course. I get you to pause the video and then, you know, come back and then build on what you found to do the next activity. So, yeah.
Fantastic. Thank you. I think that hopefully covers just some of the sort of broader themes of questions that are coming in around those really deep-seated fears and what people can get out of, what benefit they can gain from reaching out to someone around their sexual health.
So some of them, and just in summary, a lot of people who are very good at what they do, there will be a wait list. Like even before COVID, I always had a wait list to get in. Like it takes a while to get into somebody like me with Anita Elias, for example, Dr. Anita Elias, 9 months, a lot of good people. So it's a good place to start doing some of these techniques, to do some pre-session kind of or therapy preparation as a stepping stone, getting to know yourself, getting responses, doing activities. That book is pretty much activity based or something like that. And then you've got a lot of details to take with you to the therapist or your doctor or your wonderful cancer nurse or your great, you know, counselor, to just go, this is what I've discovered, or this is where I got stuck. And this is really what I want specific help on as well. So that may be another way to just kind of pace, going back to that wonderful word, timing, which is often difficult as well.
Yeah.
I have to say, Amanda, that was a really sensitive, thorough, informative, practical exploration of a lot of the themes that obviously a lot of people experience, not just the people watching today with the blood cancer. So thank you for that. And thank you so much to everyone watching and for all of their input. I think it's quite evident that to spark desire and arousal, that we need to remember we have our own inner resources, and that idea that we can shift and reset from that place of fear and go to a place of fun and joy and play in micro moments and build on that is a beautiful skill that can benefit all of us. And I think the benefits of sexual health and that physical connection are patently apparent to all of us. And so any way that we can build that self-confidence and start from a small place and let that blossom is going to be advantageous to us all. It's just been fantastic to listen. I think we've got to remind you that this is being recorded. So if you didn't get it all on the first go round, immerse yourself again and pick up some more information. We'd love to hear your feedback and suggestions for future topics. I think fertility is definitely one that's come out of today, and there's a few others. So check out the recording on our website and our YouTube channel. Have a look at our calendar of future events. And if you do have any concerns or questions that have come up from today, give us a call on 1800 620 420. We'll do our very best to answer them or point you in the right direction. So please use the information from today to inform discussion with your family, with your partners, with your treating team, or whoever it is that helps you navigate your blood cancer and living your best life. Thank you so much for attending. We've really loved presenting this, and we're so grateful that you've received this with an open heart. See you next time.